Hi guys, welcome to another episode of Maruthuvar on Real Take. This is Dr. Dona and I have here with me Dr. Praveen, who is currently working as a medical registrar. Hi Praveen, how are you?
I'm good, thank you. How are you?
I'm good. Thank you so much for coming today. I know you were working a few hours before. How was the work?
Yeah, it was good. As usual, it's a bit hectic in gastro and that's okay, yeah.
Okay, so what does gastroenterology really entail?
We deal with stomach related issues, which means anything to do with your stomach, intestines, large bowels, small bowels, and liver specifically, and your gallbladder. I am very much interested in liver, and there is other interesting field in gastroenterology, which is luminal gastroenterology, where we deal with diseases like inflammatory bowel diseases, diverticular diseases, and stuff like that.
You did your schooling, your medical schooling in India, and you did part of your training there. So if we take a step back, so how did that work? How was the training there?
So back in India, I think the med school is almost the same. So we have 4 to 5 years of med school, and then 1 year of training as a foundation doctor. Here you guys do 2 years. We call it as internship, where we stay in the hospital for the whole day. We call resident doctors and we stay inside the hospital campus.
So here we usually, like you said, we have 2 years of foundation training post our medical school, where we usually what happens is 4 months of different rotations, and sometimes we don't get to do all the rotations. So you said you get to do all the specialities.
All the specialties.
So then how long do you spend in each one in a year as well?
It depends on the specialty. Medicine, surgery, obs, gynae, and peds, they take the chunk of those 1 year. The remaining specialties like dermatology, ophthalm, ENT, radiology, we rotate for 2 weeks in every specialty. So everyone will rotate in all the specialties in a year. 6 units with a consultant in charge for each unit. So if unit 1 is Monday, they have their on-call on Monday, and unit 2 is Tuesday, they have their on-call on Tuesday. It means whatever medical cases comes on Monday, it's the responsibility of the unit 1 team. We don't have consultants to post-take and stuff. It's just the interns and the IMTs. They run the whole medical take list patients, and it's like they have to work 24 to 36 hours. So the next day until Tuesday afternoon, they will present the cases to the consultant the next day morning. So until Tuesday afternoon. So it's a bit hectic. All the specialties, the surgery, obs, gynae, everything works the same way, and you'll get a lot of on-calls and you will get to see lots and lots of patients in a short period of time. Here I think it's more resident friendly in terms of hours of work you do. For example, you do 12 hours maximum, and no one can force you to work more than 12 hours. There, if you start Monday morning 8 o'clock, then finishing at Tuesday afternoon is...
Wow, that sounds really horrible, honestly, because, you know, a whole day, I can't imagine working throughout a whole day and a night. It sounds so hectic.
Yeah.
So when you present, after you present your cases on Tuesday, what happens to those patients? Like, who takes over the care?
No, the patient will stay under that particular
your team,
that
under
unit.
your team,
Yeah,
okay.
under that unit.
And then the Tuesday team is different. They take the emergency cases that comes on Tuesday.
Yeah, yeah.
So then do you continue your work throughout Tuesday?
Tuesday afternoon, I think we'll get a little bit free time, and then we need to come back Tuesday night to see the patients and then give them the injections and stuff. So here the nurses do all the stuff, giving injection, giving fluids, all those stuff. There, where I did my mid school, we need to give the antibiotics all the drugs, furosemides, whatever we are giving, we need to give it to the patients, the injections. The nurses will just give the fluids. So
it's very different. It sounds
it's
like
very
a very different
yeah.
system. So when do you ever get days off? Is it after a period of a week or?
No off. You work Monday the whole day, Tuesday, and then a little bit of rest on Tuesday, and then you have to come again on Wednesday, Thursday. The thing is, your workload slowly decreases when the days pass by. If your unit is one and you are on call days on Monday, so Tuesday you'll try to discharge most of the patients who just needed some emergency care, and there'll be less patients on Wednesday, and subsequently there'll be less patients on Thursday. So your workload decreases, and towards the end of the week, like Friday, Saturday, and Sunday, you'll be a little more free and relaxed. And again,
Monday you start again.
Yeah. But there is no off days during your foundation training.
So just to emphasize, you come in Saturday, Sunday as well, regardless of the workload.
Yes. Saturday, Sunday, giving antibiotics, dues, all those stuff.
அசிங்கப்பட்டேன், அவமானப்பட்டேன், வெட்கப்பட்டேன், வேதனைப்பட்டேன், துக்கப்பட்டேன், துயரப்பட்டேன், கஷ்டப்பட்டேன், கவலைப்பட்டேன். இத்தனை பட்டு இன்னும் திருந்தலே குரு. யாரடா சொல்ற? பொதுவா சொன்ன குருவே.
I don't know what to say to this because honestly, medicine is so hectic. You know, it doesn't matter what speciality you're in, you need that break. And even here, like you're saying, we get breaks, but then even we feel sometimes the workload is so much, we're so understaffed that sometimes we feel the break is not enough.
It's not good to have, it's not healthy to have this hectic and tiring duty for the doctor as well as for the patient. Like it's if you continuously work for a lot of time, there is a high chance that you might tend to do mistakes.
Of course.
And it's not healthy for you as a person as well. The other side of this is you learn to work under pressure. You learn to work under stressful situation. You learn to manage even if there are a lot of patients coming in, even if you work for a long period. So there are two sides for it. So my personal opinion is that this is not good working culture to work like this.
I agree. I think you can still have a healthy learning environment where you're still dealing with, you know, different cases and you're learning without it affecting your health significantly. Because I think, like you said, an important point is that if it's unhealthy and you're feeling fatigued, then you can be prone to make mistakes because we're all humans, isn't it?
Yes,
and
of course.
it's going to decrease patient care. It's not going to be good for you either. So coming back to here, how do you feel having come here and having, you know, designated just days off?
So, as I said, as I got used to work under pressure and stressful situations, I feel it's good here to have good break after your on calls, hectic on calls. I'm not saying it's relaxed here on calls. The on calls are very hectic here as well, but the duration is limited, like 12 hours. But in that 12 hours, when compared to back home, I think the stress is at least twice as it was back home. The stress of managing patients in terms of the administrative logistic issues, bed pressures. I feel it's very good to have that break after the on call. But sometimes having continuous 4 days or 12 hours shift, bit overwhelming, but I think it's at least limited and I'm getting good off after that. So that helps me to rejuvenate myself.
Definitely. And going back to your rota from India, so do you have like annual leaves and things? Because we here have designated days that we can, you know, we have a limited number of days that we can take off. Is that the same in India?
No. As far as I'm aware, during my foundation training, the internship, which we call in India, I hardly took any leave.
So what if there's like an emergency or something, you just tell the team or?
Yeah, even if it's emergency, we need to inform the consultant, the HOD, head of the department. There is no concept of rota coordinator, nothing. There is no any set leave designated for interns like foundation doctors. Not aware.
You talked about how hectic it was during your training. Is that one of those things that thought about, made you think about moving to UK?
Not really. There are a lot of factors. So if I say hectic, definitely it was hectic for these 4 specialties: medicine, surgery, obstetrics, and pediatrics. So in between, I did get some rotations. Everyone will get rotations in dermatology, radiology. They are very easy peasy. I mean, just go in the morning, just chill, relax, stay till afternoon, and then you come back and just relax. It's very relaxing. So the 1 year, it was a bit balanced. I'm not a person who likes to be relaxed most of the time. So I like seeing patients, dealing with lots of issues, constructing differential diagnosis and doing investigations to see what exactly is going on. Like,
நம்ம யாருன்றது முக்கியம் இல்ல, நம்மளால என்ன முடியும்ன்றது தான் முக்கியம்.
The main factor which made me to move to the UK is number one, I like doing this even if it's a bit hectic. You work like for 12 hours, 24 hours continuously, but the credit you get out of it is not worth enough to do that much. So for example, here I am well supported by my consultant.
பின்னால ஒரு கூட்டமே நிக்குது.
They help me in my training applications, and they try to encourage me to do some presentations, projects, so that it boosts me and it makes me to work more. UK, there is a lot of flexible options. Like, I can come here directly as a registrar with my experience as a medical trainee there, as an IMT 3. I finished my IMT 3 there. There we call it as MD medicine. So it is equivalent to IMT here, 3 years. So I've done my 3 years of MD medicine, which is the IMT. So here I can directly join as a registrar. So from there I can start applying for my super specialty. So that's why I preferred UK rather than US, because in US I need to do medicine training there again for 3 years.
Okay. In terms of any exams and application, what kind of things and when did you start preparing?
Yeah, I think there are various routes to come to the UK. One is through PLAB. Anyone after finishing their primary medical qualification can write PLAB. It's a 2-part exam, and with the PLAB you can apply for your GMC registration, and with that you can apply for jobs here. But I didn't come through PLAB. There is another route through MRCP. So if you finish all the 3 parts of MRCP, then you can apply through that for GMC registration. With that you can apply for jobs here. But unfortunately I didn't have my PACES, but that's the 3rd part of MRCP. 3rd part of MRCP. I didn't complete that when I was moving to the UK. So I moved through a different path called sponsorship route, where there is some organization called BAPIO, which is British Associations for Physicians of Indian Origin. They have close tie-ups with GMC, and they are recruitment leads, and they recruit people, especially with 3 years medical experience, like equivalent to IMT experience in India, and then they give sponsorship. Then through that I applied for jobs, and then I finally ended up here. It's not that not everyone can give sponsorship. There is only certain organization which GMC approves can give that. So BAPE is one of those organizations which GMC has approved.
I think a lot of people who are, from India and things, they're familiar with the PLAB, but they might not be necessarily be familiar with the other routes that you've mentioned. So it's something that they can look into as well. So apart from the logistics of that application-wise, the other side is obviously because you've lived in India, you have family, friends there. So was that a barrier, and did you get homesick when you've moved here so far away?
Not really. Actually, I'm married and my wife is also a doctor. So obviously we miss our family, but as we both are together, we didn't miss much. And
so the advice you would give to people applying is that not to apply as single, they should find a partner and then move here.
I would say so, yeah.
You want to specialize in gastroenterology or go down that route?
I was a bit interested in nephrology and hepatology. Both are transplant specialties. Like most of the transplants are renal transplant, liver transplant. So back home where I did my medicine training, PGI, it's a very big center for renal transplant, and it's a very big center for nephrology and also hepatology. So I was interested in those specialties. I'm not very much into gastroenterology per se, but I'm okay with any of the medical specialties because my major interest is in general medicine.
Mm-hmm. In terms of the procedures and how you work, is there a huge difference between the protocols and guidelines there compared to here, or it's quite similar?
I think it's quite similar. In India, we follow mostly the European guidelines. There is no much difference in guidelines and protocol because we follow the European guidelines back home.
And just going back to another interesting thing you actually mentioned a few minutes back, you were talking about the social sides of things and the administrative sides of things. Is that something that doesn't really exist as much in India?
Yeah, of course. No. Initially, I thought what this social care is, what placement is, why the patient is ready to go home, but still they are in hospital waiting for some package of care. I was not totally understanding all those initially. Then I slowly got used to it. Back home, there is no any social elements into the healthcare system. So I think it's very different here. I would say it's very good in one aspect. It's really good, like we are treating the patient and we just not leaving them alone after treating them. We just make sure that they are socially okay and is it safe to send them home, all those stuff. In that aspect it's good. But in one aspect what I feel is patient medically fit, ready to go home but staying in hospital for a long time. I think it's putting pressure on other patients who are waiting for bed. If we create a parallel service attached to this hospital where we transfer all the medically fit patients and employ some staff there, I think medically fit patient doesn't need a regular doctor's input. So nursing staff and healthcare assistants to look after them, and a dedicated doctor appointed for that building. For example, if they need some medical input or if they need some medical advice, if the patient is becoming unwell or some sort of stuff like that, this doctor can help them. So in that way, we can offload these patients to a separate system and we will get more beds, and then we'll just have patient who needs active medical input and active medical monitoring rather than keeping medically fit patients in the ward.
That's a really important point that you raise here though, because like working here as well, especially on specialities like geriatrics, I see so many patients we say are medically fit, surgically fit, then they catch an infection, and then they become no longer medically fit, and then they unfortunately do deteriorate. So I think having some sort of intervention to manage this would be something that would be really helpful for patients and for us as well. So how did they manage these social issues in India? Is it usually like the family and friends who would look after them? Okay.
I think there is no any social element back home. I think if we say a patient is medically fit, like we can discharge the patient, we just discharge them. We didn't think about where they will go if we discharge them. Is it safe for them to be at their home? And I think it's very good here in one aspect that it's a holistic approach. We involve doctors, nurses, physiotherapists, occupational therapists, pharmacists. Everyone works together as a team for a patient, for a particular patient. Back home it's doctor's decision, discharge, means patient goes home.
And then going forward for the future, so is this like a temporary couple of years that you've come to the UK, or are you thinking you're going to stay here for the rest of your life, or you don't know?
So our plan is to stay here for long term, hopefully currently I'm doing a trust grade job. I'm not into actual training. So the plan is to get into training and hopefully complete training here in the UK and then to stay here long term. That's the plan by far.
Can't you apply straight to training from India to here, or did you need to go through that trust grade?
If you're doing internal medicine training or core surgical training or basic training after a foundation program, I think you don't have to work here in the NHS. You can directly apply from India, but you just need some forms to be signed off. Even from Indian consultant is fine, saying that this so-and-so doctor is capable of all those foundation year competencies, and with that form you can apply for your training. But for higher specialty training, you need to get signed off by an NHS consultant with GMC number. So
you need kind of a year of experience before you can go, fine, I get you now.
Or I think there is another option as well. If you're from other country like India, you can still directly apply for higher specialty training, provided that the form is signed by a consultant who has NHS experience and has got GMC number. I personally would say to gain some experience as a trust grade, so that it will give you good experience of how NHS functions and what you need to learn and do as a medical registrar during your on calls. That 1 or 2 years will give you good exposure to the system, and in that time you will be able to get signed off for all the competencies from your consultant.
Okay, so, and then applying after that year, do you need to do what is the process? Is it just an application form and you can go straight into the next year of training?
Yeah, it's just
as a registrar.
Yeah, so the criteria is as an international medical graduate, as I said, I need to get that form signed off from the consultant who has got GMC number working in the NHS. It's going to be my supervisor, number one. Number two, I need to complete my MRCP. So thankfully I've completed my MRCP. So I'm planning to apply this year. So the application process itself is just applying online through Oriel, and then based on the self-assessment scoring system, they will shortlist an interview, and then based on the self-assessment score plus interview score, they will rank you, and based on the rank, you'll get appointment as a training registrar.
Thank you so much for sharing that with us and sharing those experiences and those tips and the resources that you were mentioning. So I think it would be really helpful for anyone watching this who are back in India, back from another country outside of the UK, thinking to move here. So thank you so much for that. Hi guys, welcome back to our next section, which is quite interesting because we have 10 questions for you, which are medically based. And you've mentioned that you have a lot of medical knowledge from India, so I hope you use all of that for these questions because we'll be sending these to your supervisors.
Oh my God.
No, I'm only joking. We're not going to be doing that. But you have 10 questions to answer basically, and you have 10 seconds to answer. All right?
Okay.
You ready?
I'll try.
Okay. Okay, great. That's all we need. Trying. So first question. What is the first line drug management for patients with postpartum hemorrhage?
Oxytocin?
Yes. Second question. How frequently is cervical smear test performed for a 50-year-old woman?
Oh, I'm not entirely sure. I can guess.
Yes.
Yearly once?
No.
Once in 5 years?
So you said two answers, yeah? So your first one, we'll have to take that. It's not annual, it's every 5 years.
Oh, okay.
Yeah,
the second one was right.
Yeah. So just make sure when you're guessing, okay? It's just one answer, that's it, okay? There's no second goes, okay? Third one, name one drug that can cause malignant hypothermia.
Malignant hypothermia. Antipsychotic drugs?
You're just on time. Just on time. You've said it. So yeah, antipsychotics is one of the drugs. Number 4. How long can you section a patient under Section 2 of the Mental Health Act?
28 days?
Yes. What is the first line management for patients with syphilis?
Benzyl penicillin.
What route?
IM.
Yes. Okay, good. Next one, 6th. Okay, so we're more than halfway through. Well, just halfway through, right? Number 6, what is the name of the white spot seen in a child's mouth with measles?
Coplic spots?
Yes. Okay, good, great. Number 7, which drug is used to manage children with croup?
Steroids?
What?
I'm not sure.
Pick. Well, too late now. I was like, take a guess. Dexamethasone.
Okay.
Yeah. Okay, number 8. What ultrasound sign would you see in patients with ovarian torsion?
Ultrasound. Oh. I'm not good in radiology. I'm not really sure.
Take a guess, anything.
It's difficult to guess a sign.
Whirlpool sign.
Oh, okay. I haven't heard of this before.
What is the first line management for a patient with scabies?
Permethrin?
Yes.
Topical permethrin.
Good, yeah. And your last question, which drug can be used in the medical management of an ectopic pregnancy?
Methotrexate.
Yes. There you go. You said you weren't good with, obs and gynae and things, but there we go. You got that question right. So we're going to move on to our last and final section. So this is a case presentation. So you're going to talk about an interesting patient or a case that you've seen where we can learn something from.
Okay. There's a middle-aged gentleman who has got background history of alcohol excess and a bit of chronic liver disease. It's compensated. This gentleman once presented to hospital with difficulty in walking and some problems with his legs, like feeling off legs and some numbness and tingling, all those stuff. It's quite a short history of those symptoms. So he was very stable though, and he was seen in same-day emergency care unit. Initially, the working diagnosis was alcohol-induced peripheral neuropathy. So everyone agreed that it's alcohol-induced peripheral neuropathy. And then he was discharged home, saying that he needs to, of course, stop alcohol and some vitamin supplements and neurology follow-up as outpatient. He represented 2 days later with similar symptoms, but this time it was progressive. And then now, this is the first time I'm coming into picture of this patient, and he was seen by my consultant as well, and we found that he has got ascending paralysis. So now, previously he was able to walk, but now he was not able to walk at all because it's completely flaccid. It's ascending flaccid paralysis. So what is striking in your mind?
Ascending paralysis,
Yeah.
would be B12 deficiency, GBS.
Okay. Yeah.
Yeah.
I will put B12 deficiency later on in the cards because this very short history, quickly ascending flaccid paralysis, it goes entirely with GBS.
Yeah.
So I think if you would have explored the history a little bit more during his first presentation, I think we would have established the diagnosis of GBS even before. And we would have started him on treatment. His weakness wouldn't have progressed this much. Yeah, it's a learning point. It's a very good learning case. Everyone would have thought it's very much likely alcohol-induced peripheral neuropathy because he has got multiple admissions with alcohol excess ethanol withdrawal and has got one organ affected already by alcohol. So there is high chance that he might have had alcohol-induced peripheral neuropathy. GBS is a reversible condition, and if you treat the patient with good steroid and immunosuppressant, then it gives almost full recovery, and the patient will be able to walk and do whatever they were doing before. So the learning point in that is, number one, exploring the history a bit more in the initial presentation, asking about, usually GBS comes after a viral prodrome, so history of any recent viral prodrome and doing a complete neurological examination. And I think everyone got carried away by the fact that he is chronic alcoholic and it's very much likely peripheral neuropathy. And I think we need to think out of the box, try not to fix one issue with a particular etiology, like in this case to alcohol. I think we need to think out of the box. We should always construct a differential diagnosis in whatever patient we see. We get to the diagnosis only after investigations. So initially we can't give a straightforward diagnosis.
Actually, sometimes it helps to look at, okay, what's new now,
Yeah,
rather
yeah.
than the whole picture.
Yeah.
So thank you so much for sharing that with us. I think that would be really helpful. That can, we can take that to, apply it to any other patients, any cases that we see as well.
Yeah.
Thank you so much for talking to us, Praveen.
It's my pleasure.
It's been really nice to have you, and hopefully we get to work around more soon.
Of course.
And thank you so much, and thank you guys for watching, and I'll see you guys again for another episode.
Thank you so much. Thank you.